Welcome back, everybody. How is our sound? Dr. Mendelson, go ahead and say hello so we can check and make sure they can hear you.
Hi, I'm Dr. John Mendelson. Can everyone hear me? And are you asleep yet?
All right, everybody says it sounds good. So, once again, I am Jenny Williamson, Executive Director of the C3 Foundation. On behalf of myself and our founder and CEO, Claudia Christian, we're glad you're watching our second annual virtual TSM conference, Stronger Than Your Drink. Please feel free to use the chat function if you're watching live on Twitch to ask questions all throughout the panel. I'll be collecting those questions and asking our presenter your questions during the Q&A following the presentation. This conference is available to view and to participate in for free, thanks to our two co-headline sponsors, Ria Health and Work It Health. If you would like to support the work of the C3 Foundation, there's a donation link in our profile, and we also have a timer that will drop a donation link into the chat during the broadcast. And if you're on Twitter, please feel free to live tweet our conference with the hashtags Stronger Than Your Drink and Options Save Lives. It's a great way to amplify the impact of our conference and bring in new viewers. Next up, we have Dr. Mendelson presenting about using clinical pharmacology to improve the Sinclair method. The panel is sponsored by R Street Institute. Dr. John Mendelson is an established researcher and physician in the field of addiction treatment with decades of frontline experience and dozens of peer-reviewed studies to his credit. He is currently Chief Medical Officer at Ria Health and Clinical Professor of Medicine at University of California, San Francisco. As a researcher, Dr. Mendelson has published extensive work on medication-assisted treatment and the biology of addiction. Dr. Mendelson is the founder and director of the Addiction and Pharmacology Research Laboratory at California Pacific Medical Center. As a board-certified internist, Dr. Mendelson has treated addiction in his private practice for over 30 years. From 2014 to 2017, he was also medical director of BAART, the Bay Area Addiction Research and Treatment, supervising 5 opioid treatment clinics serving approximately 3,500 patients per day. Dr. Mendelson is a vocal advocate for measurable, scientifically based treatment. In 2015, he founded Ria Health, offering support for alcohol misuse through a telemedicine app. This platform uses evidence-based techniques such as medication, coaching, and digital tracking tools to help people cut back or quit drinking on their own terms. It is Dr. Mendelson's hope that this will bring affordable, evidence-based care into the mainstream. So with that, Dr. Mendelson, whenever you are ready, I'm going to go ahead and hide myself from the broadcast, and you can start whenever you're ready.
Okay, great. Well, welcome everyone. It's always interesting to do a call on a conference on online because you really have no idea if anyone's there, and you have no idea who's fallen asleep yet. So I'm hoping that you guys are all comfortable. You have someplace nice and warm, and you have like a little, like your little teddy bears and blankies, and you're ready to go take a nap because I'm going to help you with that over the next hour. Hopefully not too much. And let's take a look here. It's going to go this way. Let's see if it moves. I think I got to go here. There we go. So in terms of disclosures, I am the founder and chief medical officer of Ria Health. I do have a financial interest in the company, and I don't have any other conflicts of interest relative to this conference. But I've been consultant for pharmaceutical companies. I've done medical legal cases. So there are other things I've done that could be considered a conflict. And I'm glad to discuss any of those with you and how it might affect the presentation if you have any questions. So this presentation does include science, right? And so this is a trigger warning, right? It does include numbers, and I know some people are allergic to those, but I promise we'll keep it humorous. We won't make the numbers subtract from the thing from the presentation, and the jokes will be really serious. They will not be funny at all. So they're just there to make you more comfortable with the science and the numbers. The perspective of a clinical pharmacologist, first I'm going to give you a little historical perspective on alcohol, and then I'm going to talk about talk about how we really use pharmacology. And this really is the story I'm going to tell now. Really is the very first story of clinical pharmacology, and the very first story, at least in Abrahamic religions, of consequences of alcohol. And for those of you who know it, it's really quite a great story. It's the drunkenness of Noah. This picture, this picture is from the roof of the Sistine Chapel, painted by Michelangelo. And we may notice we've had to put little squares over the genitalia here, and that's required by Twitch, which does not let you show any kind of human genitalia, but apparently lets you show single-person shooter games ad nauseum. And so long as you don't shoot them in someplace private, right? But actually, I've never played those games. I wonder if that actually happens. At any rate, the drunkenness of Noah is a great story. It's in Genesis. And what happens is after the flood, Noah starts to plant grapes and till the land, and somehow he has 3 sons with Mrs. Noah, right? And which can't be discussed on Twitch. And one day, about 600 years in, he gets hammered. He gets totally hammered on wine, because that's what that big vat in the back is his fermentation vat, and there's a little pitcher in the front, which is the pitcher he drinks from. He gets completely hammered, and is naked. He's naked, drunk, and lying on the ground. And his sons see him, and because they're afraid their dad will think badly of them if they observe him in his nakedness, not his drunkenness, his nakedness. They back in and attempt to cover him with a cloth. But while they're doing that, Noah rouses himself and realizes that at least one of the sons has seen him naked, and he banishes that son, Ham, from the family, throws him out. So it's a bizarre story. It's a completely bizarre story. How is this an origin story? Well, if you look at it in the modern context, we have a drunken parent and a family intervention, and that fails, and it breaks up the family, right? And this is a story we see all the time where someone's drug or alcohol use results in a fracture in the family and a removal of one family member. Now, the story of Ham gets pretty darn complicated, and it actually ties to modern racism, since he was the darkest one and he was banished. And but we'll save that for another series of talks at some other time. The drunkenness of Noah is rarely reinterpreted in the modern context, but here it is today. This guy's a guy named ADME. He's a Sephardic Iranian Jew living in Israel, and this is what he thinks Noah would look like today. And I think we've all seen Noah. I think we've seen Noah in our communities, lying on the ground, naked and alone. So what we're going to do today is I'm going to give you a brief review of the pharmacology of alcohol. I'm going to integrate harm reduction and alcohol pharmacology, and I'm going to discuss how a better understanding of pharmacology can improve your application of the Sinclair method. That's the real goal here, to extend your ability to treat your patients better. Pharmacology, there are really 2 sides of pharmacology. There's something called pharmacokinetics, and there's something called pharmacodynamics. And we'll talk about harm reduction first. We'll come back and define PK and PD in a minute. So harm reduction is not just being able to use the drug you want, where you want to use it, when you want to use it, and with no consequence to you. That was the libertarian view of harm reduction many years ago. I can do drugs, who cares? As long as I'm not doing anything else. Harm reduction is a set of policies, programs, services, and actions that aim to reduce harm to individuals, communities, and society relative to drugs. Okay, and there are 4 pillars of harm reduction. We have prevention, recovery, harm reduction, treatment, recovery, and community safety. And I don't think we should ignore community safety. We're in a time now where there's a lot of debate about what the role of police is, but community safety is important and still something we need to actually have discuss in the context of what we do and treat and the problems we treat, because alcohol does lead to a great deal of crime and problems with community safety. This graph here, in terms of harm reduction, is really the essential piece of information you need to have to understand why reducing people's drinking is important. On the x-axis, we have standard drinks per day. And on the y-axis, we have relative risk. And relative risk is a statistical measurement to look at if some risk is 1 in 100, right? If the relative risk goes to 2, that means it now goes to 2 in 100 or 3. So it is a multiplicative risk index. And if it goes less than 1, that's excellent. This data is from a study published in Lancet about 2 years ago, and it is a meta-analysis. Meta-analyses combine, they take the data from many studies and normalize them in some way so that they're asking the same question. They do some math on them, and they come up with a much more powerful look. And this particular meta-analysis was amazing. It included over 690 data sources and 596 randomized trials with more than 140,000 patients and 23 independent health outcomes. And each of the health outcomes, and I can show you the slide for that, are noisier than this slide. But what you see here is an absolutely straight line. Like the line starts at about 1 drink per day and goes up linearly up till, like when you get up to 12 to 14 drinks per day, the relative risks are 2 to 3. And I got to tell you, risks greater than 1.5 have meaning. Okay. So if something is 1.5 times riskier than something else, it's something you should change, right? You want to decrease that risk. So there is, when you hear people say there is no safe level of drinking, they're actually quoting this study. Okay. Because you see the relative risk index starts at 1, but you don't get above 1.5 until you're out here about 4 to 6 drinks per day, which all authorities also agree is an excessive amount of alcohol. So this graph validates drinking levels as promulgated by various health authorities. Okay. And what's essential here is this: it's linear. These green lines represent the confidence intervals, which widen as the number of drinks climb, and it's because there's less people in those categories. But this is a very tight set of risk data, and therefore moving yourself down from 6 drinks a day down to 3 drinks a day decreases your relative risk from 1.5 for any particular health problem down to about 1.2. Right, that's a meaningful change in risk of a bad outcome. So I sort of mentioned that we need community safety. And I'm sorry, this slide probably should have been one before. So alcohol is associated with crime, and again, there are other crimes that there are other harms that were not measured in the Lancet slide. Alcohol is associated with violence, and it turns out about 40% of people in jail committed their crime. And prison committed their crime while drunk. So it dwarfs the number of people in jail for marijuana, dwarfs the number of people in jail for opiates, dwarfs everything for leading to people incarceration. And what's really fascinating, and this is a pharmacology point here, that if you look at the time of day people do violent acts that end them in jail, what do we see here? We see here that they peak for alcohol, like 10% of them occur at about 1 a.m. or 2 a.m. Why is that? Well, I'm going to present data a little bit on the biphasic effects of alcohol in terms of a dose response function. And it's partially that. People become more violent, not while they're drinking, but after they've completed their drinking episode and they're on the downward swing of their blood alcohol concentration time curve, right? So if you understand that people are going to have more problems with drinking, the later you let them, like an hour or 2 after drinking, that can inform when you want to have your police departments available in areas with high bars, with very many bars, or what time you want to end drinking, right? You may actually want to end it even later at 4 or 5 a.m. so that the day shift takes care of it, not the night shift. So harm reduction, as I just told you, is that decreasing alcohol risk decreases your risk of disease. Risk is linear with exposure. And exposure is ultimately the effect of alcohol at some specific place in your body. And pharmacology is the study of drugs at specific places in your body, right? That's what we do. We actually figure out, so if you're going to propose that you're going to decrease harms and what those harms might mean, you have to know something about the pharmacology, the effect of alcohol at that specific place in your system. So now, I told you that alcohol is a drug too, and alcohol, and this is an interesting area here. And many times in clinical pharmacology and disease, we're not, the treatment, pneumonia is not a drug. I mean, pneumonia is bacteria or viruses that are affecting your lung, but alcohol itself is a drug, and pharmacology study of drug. So studying alcohol is to actually study the disease entity as well as some of the factors around disease progression and complication. So I told you I would define pharmacokinetics in a little bit and pharmacodynamics. These are the two sort of branches of clinical pharmacology. And pharmacokinetics is really the study of drug levels in your body. The drug level, we give a drug, we measure the level, and over time it changes. And that's what your body is doing to the drug, right? So whether it gets to a certain point and how fast it gets out is totally what that's your body. And it doesn't tell you anything about the action of the drug or the effect. That study is pharmacodynamics. It's pharmacodynamics. So how a drug affects you is the pharmacodynamic effect. That's the part we're mostly interested in. But you can really think of most diseases as an interaction between PK and PD. Like you have to have a certain concentration in a certain place at a certain time, and you have to have a certain effect. And those things together define what makes it, particularly for alcohol, a disease process. If we look at the pharmacology of alcohol, we start up here. We have ethanol in a dose form. It's a beer, wine, spirits, outmixed drinks. People take it by orally. They usually don't take it other ways, but alcohol can be given intravenously. It can even be given rectally. IV alcohol had been used in hospitals to treat alcohol withdrawal for many years and preterm labor. Once you've taken it this way, the drug is absorbed, distributed, metabolized, and excreted. And this is true for all drugs. So you'll see from time to time the letters ADME along with pharmacokinetics. And this is, like you see in the newspaper, you know what it means. And this generates a concentration time curve. So that here we have concentration on the y-axis, time on the x-axis, and some curve of levels, right? And while it's doing that, it passes through as the concentration goes up, it passes through the blood-brain barrier and then does some kind of effect, pharmacodynamic effect. So when people talk about receptor binding or receptor effects, that they're talking pharmacodynamics, and that produces some kind of effects. And then you can have either, the outcomes, which are excitement, relaxation, euphoria, or intoxication with incoordination, coma, death at sufficiently high blood alcohol levels. So that's that. Let's go backwards just a sec. So we're going to proceed now through these areas, the ADME of alcohol, just to show you what it looks like, and hopefully, as I said, the goal is that you'll be able to think a little better about what this means for your patients and how and link it to these, the pharmacodynamic effects coming on. So there are two big things that are important in pharmacodynamics. One is the food effect. So whenever we eat, food goes into the stomach, and same with alcohol. And then the stomach has a muscle called the pylorus that only lets some of the food go into the small intestine at a particular time. So the food gets injected into the small intestine in little bits and pieces so that it's more easily absorbed, does not distend the small bowel. And so if you drink while eating, you have this food effect and you have delayed gastric emptying, right? And that results in a change in the blood alcohol concentration time curve. There's one incredible exception to this, and I see we have a talk tomorrow on this, and so that I'm actually going to try to catch that talk on bariatric surgery. So people who've had bariatric surgery, there are two kinds of basic procedures. One is they actually do a bypass. They actually they bypass the pylorus is what they bypass. They connect part of the small intestine directly to the stomach, so the food just flows immediately from the stomach into the small intestine, and usually do something to restrict the size of the stomach there, so that it's much smaller, and this results in overall decreased food intake, but it really changes the way alcohol is handled. Without that food effect, you just get instant loading of the small bowel with alcohol. And if you only drink alcohol without any food at all, the blood alcohol concentrations are tremendously different. Alcohol distribution. So when you drink alcohol, where does it go? It goes into your body and it gets dissolved in body water. So so depending how much water you have is how you can actually calculate it if you know your body water, and you can actually estimate that it's usually affected by gender is the most common, but fat content and mass are the two most important things. And you can actually calculate really simply what someone's blood alcohol concentration would be if you just know their body water, right? And it's that simple. Alcohol is eliminated in several places. There's actually the gastric lining has enzymes as CYP2E1. The liver has enzymes, something called alcohol dehydrogenase and aldehyde dehydrogenase, that both metabolize alcohol. And unmetabolized alcohol can be excreted in the urine and also expired in the air. So you breathe it out. That's a relatively small amount of elimination. This is your prototypic blood alcohol concentration time curve. And this is from Vijay Raghmanathan at NIAAA. And there are several people publish this. And I'm going to walk us through this, and so we understand a little about alcohol and what happens. So on the bottom on the x-axis, we have time from started drinking. T0 is there. And then we have blood alcohol concentration going on the y-axis, and we can see here that over time the blood alcohol levels rise and they peak at some point, and we call that Cmax, right? And then they peak at some point, which is called Tmax, and then they decline, and they decline linearly. They decline linearly over time. This linear decline is actually special and not seen for many other drugs. Most drugs decline exponentially. They have a curved concentration time curve where a proportion of the drug is removed, not a constant amount. And over some time period, it gets to zero. If you know on this curve, after Cmax, after maximal absorption, if you know that the concentration at this time, at any of these times, and you know the patient's weight and gender, you can actually estimate the number of drinks they took. Okay, you can do that, and that's the basis, by the way, for that. On the back of your driver's license, there's a little thing that says how many drinks you can take and what your blood alcohol concentration will be. It's going the other way, right? So if we know any of these data points after 100 minutes, we can estimate what the prior points were, and do that with really a surprising amount of reliability. You can see that there's this dotted line here has a very high correlation coefficient. And so let's unpack this a little bit more. There's the period of absorption. So after you start drinking, there's a period of time when the alcohol is moving from the small bowel, from the stomach to the small bowel into the portal circulation and then into the systemic circulation. And that's what we're measuring in the systemic circulation here. But that doesn't end at the Tmax. At the Tmax, you're still absorbing some alcohol after that, and it's still adding a little bit. And you can actually see you can see a little bump in this curve here where it's just off the average. But at some point, absorption ends, and you have only the excretion point. For people with bariatric surgery, their curve looks like this. Right, their curve looks like this. Much more rapid absorption, hence a much higher Cmax post drinking. The other properties of alcohol haven't changed in people with bariatric surgery. Right, this is an interesting look at the food effect in a different way. So I told you that in normal people, like the food effect also applies to the concentration of alcohol in the beverage. So it turns out when alcohol concentrations are greater than 20% in the stomach, that delays gastric emptying. The stomach doesn't empty as fast into the small intestine. So here we have, but we also have in this case, we have, if you're drinking beer, there's more fluid in there, and hence you have more gastric delay. So after drinking spirits, people, like, again, so long as they don't get their concentration above 20% in their stomach, and that's why you put a couple ice cubes in the bourbon, right? You get rapid entry into the stomach and rapid peak blood alcohol concentration for the same amount of alcohol. In beer, it takes longer because there's that delayed gastric emptying that occurs. These are again, how a pharmacologist takes a drink. Food. We told you that gastric emptying can be affected by food, which inhibits absorption. The alcohol content, when alcohol concentrations are between 20 and 30% in the stomach, right? Absorption is faster, but at greater than 30%, it's slower. Greater than 20%, it's a little slower too. Gastric emptying can be increased with tolerance to alcohol. The autonomic nervous system can also affect that. The autonomic nervous system, I won't get into that, but it's your fight or flight response. It also regulates heart rate. Various drugs can affect alcohol. Can affect the curve, as carbonated drinks can also affect it. And maybe one of the reasons people like rum and Coke is because yeah, I know. I have to sometimes move that little bar around to the little bar that controls all things is sometimes right over the text. It's and again, here we have another food effect slide showing you that on a empty stomach, you get much more rapid absorption. And I should tell you that almost every authority in terms of, I'm sure many of Sinclair method practitioners do recommend patients, like not drink on an empty stomach. And here's your reason why, right? The pharmacology. I told you that bariatric surgery can affect your levels. And so what this is an amazing slide. This is from Dr. Yanina Pepito, and I think she's at UNC, University of North Carolina. What you see here is that they gave patients pre-surgery and after surgery, either who had a Roux-en-Y gastric bypass or a gastric sleeve. They had them drink before their surgery and after their surgery. And the little triangles here are before surgery, right? And you can see their blood alcohol levels go up to some point and then come down in that nice linear line we've been seeing before. But after surgery, look at they double or almost triple their BACs, right? Their peak BAC. And so what you're seeing here is really a dramatic effect on absorption, right? This is all absorptive effects, and they turn essentially one drink into four, right? So for all your patients who have bariatric surgery, and we see at Ria, we see a lot of patients who are post-bariatric surgery. I'm sure many other Sinclair method people do as well. You really got to think through that you have to add. You may want to add more about spacing drinks, slowing them down. Other behaviors can be really important in that population. Okay, so this is the distribution phase. So we've talked about absorption a little. This is the distribution phase, and there aren't as many diseases. So that this phase, the alcohol is flowing like when the tide rises and the water distributes to all the tide pools. This is what's happening in that phase. It's like the alcohol is being partitioned into all areas of water in your body, and this phase is the metabolism excretion phase, and that really metabolism and excretion starts right at as the dose begins, basically, but really becomes the only dominant feature, right, for post distribution. So again, at about 100 minutes here, post dose is when in this curve you're really in the elimination phase only. There's no new alcohol being added to the system from the stomach, right? And there's no alcohol being generated someplace else by a metabolite. And so just elimination at that pace. Urine curves look a little like this. The blood curve peaks earlier, urine peaks later, and that's just because you have time in the bladder, right? So this is just bladder time. This difference is the amount of time it's sitting in the bladder. And so let's move on and talk a little about alcohol doses. Oops, pardon me a second. Can I go backwards? I think, yeah. So the dose is the standard used in pharmacology, and the base, and so when it's our unit number. The base dose of alcohol is something called a standard drink, and I'm not going to tell you what the standard drink is because it varies by country. It's not the same every place. So one country's standard drink is not another country's standard drink. In the U.S., it's about 1.5 ounces of 84 proof alcohol, and the U.S. also assumes that wine is 12% alcohol and beer is 16% alcohol, but these are not true numbers. Okay, there's hardly a wine that's 12% ethanol or beer that's 6%, and there's hardly anyone who has exactly 1.5 ounces of just distilled spirit. And the amount of water you add is important, right? The amount of water, and so the standard drink is a problem, right? So we have a problem with a unit of measurement, right? So if we're just going to count drinks, right? We're going to have trouble because those drinks are going to vary tremendously. Not even with the problem that, a guy goes to a bar, gets a drink, but it's in fact a double, right? Gets a generous pour. So it's not even the problem of the problem is fundamental. If a person's drinking one bottle of wine a night and they're drinking 18% versus 14% versus 16 versus 12% ethanol, they're different doses. If they're drinking high alcohol IPAs, that the different dose than Coors Light. Okay. So we have a problem with that. But I'm going to show you how we can get around that a little bit. And I already did show you a little, but once we're in the elimination phase of the curve, right, then we can standardize everything if we have a measurement. So ethanol is eliminated from our body. Some of it goes into sweat, that's just traces. And by the way, when people say they smell ethanol in people's breath or in their sweat, it's not the ethanol they're smelling. It's actually the congeners. It's the other flavorings in the drink. Ethanol itself is odorless and colorless, right? And pure ethanol cannot be detected on someone's breath by smelling. It can be detected in breath by breathalyzer tests. But 1 to 3% of the dose goes out in the urine. 1 to 3% of the dose goes out in breath. Most of it goes out through this pathway of oxidative metabolism in the liver, forming first acid-aldehyde, then acetic acid, then H2 and water. Some of it goes into things we actually measure, which is really interesting. So ethyl glucuronide and ethyl sulfate are where ethanol is added to a glucuronide or a sulfate molecule, and you can actually measure that. And so when you order a urine ethyl glucuronide, your ETG level, that's what you're measuring. You're measuring the direct metabolite. Now, the problem of alcohol, and you can also measure something called phosphatidylethanol, and I encourage providers to get these. These are good numbers to get. The ETG represents alcohol for it's present for the first 24 to 48 hours after a drink and goes away. The PEth, the phosphatidylethanol, is a good marker for up to 2 months. There is a lot of between individual variation. So where it's most useful for providers is to get a baseline and then to measure it over time. These tests are not commonly done. They're sometimes not covered by insurance. So there are challenges with these tests. But they are a way to look at ethanol elimination in patients, and you can use them. You can get them again if a patient's got good insurance. They can be quite useful to document improvement over time, particularly with patients you're not sure what's going on with. One thing we do. Come on, sorry there, guys. Go back up. One thing we do is you can actually measure blood alcohol concentrations, and blood alcohol concentrations can be measured directly using either blood levels or by using breathalyzers. And you can also calculate the BAC if you know about how much alcohol they drank. So if you really know the dose of alcohol someone took, you can also estimate their BAC quite easily. You need to know your weight, relative body fat, gender, and how much they drank. And there's an equation you can look up, and I'm not providing it here, but you can anyone can look this equation up and use it. It's called the Widmark equation. It was done in 1910. So people have known this relationship for a long time. And the equation has stood the test of time. Okay. So how do breathalyzers work? Breathalyzers are really cool things. They come in 3 different flavors. There's one that measures color changes. These are the least accurate, but sometimes the ones you may have been provided, like you blow into and it turns something blue right while you're blowing into it. There's infrared ones. That's the intoxilizer police departments have used for many years. That measures an infrared, that uses infrared light to actually look at absorption of ethanol. So the intoxilizer is the one that often most commonly accepted by law enforcement, but does require extensive calibration and recalibration over time. And the final are some called the fuel cell technology, the ALCA sensors. And the fuel cells are really revolutionized the field. They've made it, they're convenient, they're accurate, and they are easy to use. So how do they actually work? Right. Well, there's a little guy inside, of course, like you blow, it's a little guy and he gets drunk and when he can't walk, that's how, that's what right? So it's a tiny little human in there, right? A professor of pharmacology is inside. No, but they actually so in there there's an alcohol, an acidic matrix with some reactive acetic acid and a slight current on a platinum electrode. And when you put ethanol across it, there's a catalyzed reaction that generates an electron and some H2O in water, and that's read on the LCD display. The complication, there are a couple complications with breathalyzers that everyone should know about. First off, they can measure other alcohols, right? So they're not exclusive to ethyl alcohol. It's just that ethyl alcohol is in such high concentrations when people are drinking that it tends to dominate the signal. But the last digit on most of the breathalyzers, the third digit, is often artifact anyway, just noise, and should be ignored. Right. So, but if you get a funky reading in general, like from toothpaste or mouthwash or just other things in food, just take another reading in 10 minutes, right? 5-10 minutes, right? As I showed you on the alcohol curve, people's blood alcohol concentration is not going to drop substantially in 10 minutes, right? But their artifact concentration will change rapidly. Okay. So the other thing is that you do have to wait about 15 to 20 minutes from your last drink in order to do a breathalyzer measurement. And that's because you still have alcohol after you drink, you still have alcohol in the oropharynx and in the esophagus that can be measured. And so you get artifactually high measurements from having had a beverage recently. And finally, your gut does make alcohol. So one of the things that's happening in your gut, all of our guts right now, is fermentation. Bacteria are fermenting and they're making ethanol, and some of that ethanol can sneak by the liver and get into systemic circulation. That's uncommon, more common in people with cirrhosis or other with some kind of problem with portal hypertension. Which but at any rate, you can have artifactual ethanol production from without drinking from the liver. There's a thing called auto brewer syndrome, which is not very common, but some people really, they really do have that. So let's move a little bit to pharmacodynamics and talk about what alcohol does to your body. So we've gone through PK. We understand now that blood alcohol levels come up, they come down a linear way. And PK is not so consistent. So many things affect how we respond to alcohol, including genetics. And the most important of those is a low sensitivity to adverse effects of alcohol. Some of us think that's probably the key factor that leads people to become heavy drinkers. If cheap dates, people who can only tolerate one drink before they feel sick never become alcoholics. They may have other drug problems, but alcohol is not the one they develop. Right. So, but being able to tolerate high amounts of alcohol without having an adverse effect is something that can definitely lead to at least getting a high enough dose into your body that you can become tolerant dependent and then suffer withdrawal. Environment makes a big difference in pharmacodynamics. When you drink, what time, what the context are, and of course, age. Peak drinking occurs mostly in really young people. I mentioned this biphasic effects of alcohol curve, and I'm going to show you what it looks like a little bit. A lot of people talk about effects of alcohol use over time, and it's an interaction between this low sensitivity to adverse effects of alcohol and tolerance and dependence. And then behavioral extinction is something that's dear to the Sinclair community. And I'm going to just show you a different version of that in a second. So people, 5 minutes. Okay. Now let me hurry up. So when people drink over time, their blood alcohol levels go up, and they keep drinking, right? They actually their performance is good at some point and diminishes. And we all know that this is the quality of personal dancing with dose of alcohol, and the perceived quality, we think we're doing well when we're actually doing poorly, right? This is a wonderful piece. This is probably the first report of biphasic effects of alcohol from Ebulus in 375 BC in his play, which was titled Dionysus. And this is the setting of this play is a symposia. Symposia are places where people drank together, and they were attended by 7 to 15 people, and wine was served in craters, which were these large vessels that were then diluted into pitchers and with water. So what Ebulus says is that for sensible men, I prepare only 3 craters, one for health, which they drink first, the second for love and pleasure, and the third for sleep. After the third one is drained, wise men go home. The fourth crater is not mine anymore. It belongs to bad behavior. The fifth is for shouting. The sixth is for rudeness and insult. The seventh is for fights. The eighth for breaking the furniture. The ninth for depression. The 10th for madness and unconsciousness, right? So that's early pharmacodynamics. I'm not going to get too much into the extinction debate, but this is I always love this. Whenever I hear pharmacological extinction, I actually think of this slide from Gary Larson, showing the real reason the dinosaurs became extinct, right, was smoking. And we can talk at some other point about reward salience and extinction learning at some other point. So at Ria, what we do for patients is we issue them Bluetooth breathalyzers managed by our app. We have patients breathalyze a couple of times a day. We report they report their drinking starting times, and we know the patient's weight and gender, and hence we can calculate their BACs with more than just their from their breathalyzer data, and estimate their number of drinks, and we can estimate the number of harms. And this is the kind of data we see in Ria. These are blood alcohol concentration time curves for a particular patient over days in the program, and you can see this patient was not making much progress. Then I don't want to show you where we switched meds and changed some tax, and we got a lot of progress, and he or she rapidly decreased their blood alcohol concentrations. And we can also, because we know those numbers from the PK curves I showed you, we can estimate their number of drinks per day or per week, and have those numbers nicely shown to us. And we can also, because we know that from that slide I showed you earlier from the Lancet, we know their health outcomes, we can show you that their health outcomes have improved. And in this formulation, a great health is 4, bad health is 1, and just this counting system here. So this patient starts out at a moderately health with some moderate health challenges, but gets up to a point where their drinking is no longer considered to be impacting their health, at least by their WHO risk score. In our population, we can demonstrate that we most of our patients achieve like a 50% reduction within the first month of treatment, and over 6 months, they here at 180 days, they maintain about a 60% reduction in alcohol use. And this data, I just pulled this off our program just this morning. This is fresh data right up. We can calculate this daily. Looks the same if we use absolute BACs as the measure rather than the percent reduction. And finally, we can track WHO scores amongst all our patients. And we can see here the green is where you want people, yellow, it could be better, and red is not so good. And we take most of our patients up to from like up to 60% have a WHO score that indicates high risk for drinking. We drop that down to about like 30% at 6 to 9 months. So, at any rate, that's my talk. Pharmacology can be useful. Treatment does work, and this is just a screenshot. I meant to take another screenshot. This is a screenshot of the coaching and the team just a couple of weeks ago, or last week. We now have 69 people working for Ria, and we have a big staff, and they're all doing an amazing job. I just come along and tell the jokes. So that's it. I think if we have any questions, I'm glad to answer them. And I know I'm standing in the way of getting to the movie. So
yeah, well, we don't have much time for questions. So unfortunately, I'm going to have to skip the audience questions and go with just our 2 standard questions that we're asking everyone. First, in your TSM patients, what would you say is the overall success rate?
Well, I think I showed that in some ways. I'm showing it to you. It's like it's at least 50% to 60%. I mean, naltrexone is our first line drug, and so we do use other medications as well. And so I think that if you're going to define success as reduced alcohol intake, right? We're achieving that in most of our patients. And we're achieving it. We're achieving a 50% reduction quickly, and we're achieving these WHO outcome improvements quickly as well, right? So there is this population, up here at the 10% or so that don't get any meaningful change in their risk reduction score, and there are people who don't suppress their alcohol use. And that's your second question. What maybe why? What do I think is going on, right? Why isn't it working, right? Might be your
No, actually, my second question is another one that I'm asking everybody, and this is because we are just about out of time. But how does TSM make your patients stronger than their drink?
Oh, it gives them a great deal of control. It's a really very nice. I mean, what's great about TSM is patients often feel powerless in to do things in medicine. They all want to do something to help themselves out. And TSM is a great way to give people control. It links their treatment with their disease quite directly, and gives them hope. Gives them hope that they'll get to some outcome point with, so I think it's a fantastic method. Again, like all medical interventions, you need to think through for the individual patient. There are a lot of other things that need to be done. There's no one path through most problems. But I recommend it, and I think we support it.
Wonderful. Well, thank you so much, Dr. Mendelson, for participating in our second annual TSM conference, Stronger Than Your Drink. We would like to thank you as the co-founder of Ria Health, along with Work at Health and our panel sponsor, Our Street Institute. We're going to take a short break, prepare for our One Little Pill watch party. We are going to go offline briefly while we transition into the different screen for being able to run the watch party and before we run our next intermission. And we are going to come back as close to 5 p.m. Eastern as we can. We're going to have Claudia with us for the film. And the watch party and Q&A portion of our conference is only going to be live. It is not going to be available for replay. So if you want to see this and participate in the Q&A, please stick around after we go offline real quick and then come back. So thank you again, Dr. Mendelson. Thank you, everybody out there. We will see you very soon.
Take care. Bye.